Okay. There we go. Yeah, so how did you guys do, you think? Pretty good?
According to Shadow Health, I did fine.
Yeah.
Did the review help you prior to it?
Yeah.
Okay, good. I'm glad it set you up for success, I'm sure. I didn't read anybody's stuff yet, but I will. I was at work all day and it was just like insanity. Dennis, did you see the kid last week that came in that was bitten by the pit bull?
I came in, I guess they finished up at like 12:30 and I came in at 3. So I heard about it. But I heard the kid was messed up. St. Joe's like intubated him and then they gave him a PD escort to get there.
Yeah, so he was a 9-month-old, and I don't know that you probably know more of the story than I do, but a pit bull literally mauled his face.
Yeah, it was like the grandparent. He was at the grandparents' house. It was the grandparents' dog. And apparently the kid, I don't know, they said the kid was crawling near his food. They don't know if he went and reached into the dog's bowl or something.
Oh.
You know, these pit bulls have like such a bad rep because look what happens.
I know. Yeah, and unfortunately, I don't know in this case, you might know more than me, but he went up to the ICU, but I'm in the step-down ICU, so I'm in a different area. But and we've had this before, if the pit bull or a dog, usually it's always a pit, though, if a pit bull bites them, and if they go for the neck, it's really serious because then that's their trachea, right? And then they usually have to either trach them or they have to reconstruct their whole airway. There was a kid last spring that came in and they had to reconstruct her whole airway, and she was actually like having air leaks like out of the trachea because I guess they didn't like sew it up like 100%, or they do the best that they can, but there's always, they're humans too, right? And if you're bitten, it's not a clean cut, it's a messy cut, so they have to sew it back together. And in the event they sew it back together, they got to make sure it's not leaking air through your trachea, your windpipe. And with her, it was just leaking air. So they had to bring her back to the OR, and they eventually fixed it. And she actually is okay. She's just got like, her face is just so messed up. And it's so sad because she's like this little baby. I think she was like 1.5 maybe. So dog bites are real. No joke. Anyway, moving on. I know it's late and I apologize for the late Zoom, but one of my friends needed an emergency switch. So that's hence why we're doing it at night. Anyway, so next week it will be our final week. The topics for next week are cystic fibrosis, pyloric stenosis, and meningitis. So these are not shadow health. This week was your last week of shadow health. So next week you have 3 ATIs, 2 on cystic fibrosis and 1 on oxygenation. And then you have to complete the 2 case studies on pyloric stenosis and meningitis. So I just want to talk about what cystic fibrosis is. Anne-Marie taught you this already, right?
Mm-hmm. Mm-hmm.
Okay, so what is cystic fibrosis?
It's like a buildup of mucus in your lungs, right? And they have a problem with getting it out.
Right. So it's a genetic disorder that they're actually lacking the enzyme to loosen up your secretions. Because we, as non-genetic, non-cystic fibrosis people, we have a certain enzyme in our bodies that actually loosens our secretions up. They don't have that. They also don't have the pancreatic enzymes to break down certain fats in their pancreas. So when they eat, they have to sprinkle pancreatic enzymes on every meal that they eat to help give them those enzymes to break down the foods. They're usually very, very skinny with these big pot bellies for some reason. They usually almost always have ascites. They always have clubbing on the fingertips and the feet. That usually is more prominent in older cystic fibrosis patients. They're usually really, really thin because their body is working so much overtime to maintain their oxygenation status. So with that being said, they're burning so many calories doing so. So they need extra calories just to maintain their normal caloric daily needs, because their daily needs are higher than ours. So in this case, it just, you know what, I'm not really familiar with this ATI one because this one's a new one. But in cystic fibrosis patients, what would be your focus for them?
Airway, firstly.
Airway, right? Airway, maintain their airway. Pulmonary toileting, and when I say pulmonary toileting, I mean chest PT. You guys know what chest PT is? It's when they pat them on the chest to help make it help. It gives vibration throughout the chest and actually helps them cough and get out the mucus. But with what we do with these cystic fibrosis patients is we do something called a chest vest. So we wrap this like pad around their chest and you turn it on and it vibrates. And that takes the place of the chest PT that we would do manually. So it vibrates the chest, helps the mucus come up with the patient coughing, and helps clear their airway, hence pulmonary toileting, right? So we do the chest vest. We do, what else do? They do a lot of treatments, a lot of nebulizing treatments, a lot of 3% normal salines to help loosen the secretions within their lungs, and they get it around the clock, pretty much like forever. These kids, they're pretty amazing because they know more about their disorder than we do, and they do everything themselves pretty much. They know to take their pancreatic enzymes, but sometimes you get that rebellious child who says, I don't have to do this anymore. I don't want to live like this anymore. I don't want to be different. And then they don't take care of themselves, which is very, very bad. Same thing with, like I said, like kids with diabetes, they almost get rebellious and they say like, I don't have to live like this anymore. I'm not going to do what you tell me to do. Which is really sad because the more compliant a cystic fibrosis patient is, the longer they will live. The better they take care of themselves, the longer they will live. And they usually live probably 30s now, maybe 40s. Sometimes they just get like severe pneumonia and their lungs have a lot of scarring on them, and then they can't handle what we can handle. So sometimes they don't always make it. But they actually came out with this new drug. It's super, super expensive through insurance. Insurance doesn't always cover it. But so cystic fibrosis is a genetic disorder, right? So two parents have to carry the gene in order to make a child that has full-blown cystic fibrosis, okay? So these two parents, so you or I, we don't have the cystic fibrosis gene. So let's just say we breathe at 100% lung capacity, okay? A person who's a carrier of the cystic fibrosis gene, let's say, has a 70% lung capacity. And the person who has full-blown cystic fibrosis, the actual disease, breathes at 50% capacity. So this drug now, if a cystic fibrosis patient who has the full-blown disorder takes this drug, it will bring their lung capacity up to carrier status. So it'll bring their lung capacity up to 70%.
Wow.
Yeah, so that's like a big deal. This was like a few years ago I heard about it, and at that time it was super, super expensive and insurance wasn't covering it at all, which I think is so unethical, but you know, that's insurance companies for you. So I don't know. I got to find out like the recent research with the drug, but I just thought that was just so interesting because it's almost like they could live now. If they take this drug, they can live at a carrier status lung capacity, which is totally livable, right? So that's big deal. I know that when they come into the hospital, these kids are always colonized with bacteria. So they can't be in the same room as another cystic fibrosis patient because then they could transfer bacteria back and forth to each other and wind up getting worsening, like very sick. But we did have a set of 2 twin girls. They were probably a year apart. They both had cystic fibrosis because their parents were both carriers. And we kept them in the same room because they live at home, so they're pretty much colonized with the same bacteria, right? So it didn't matter if they weren't going to pass one to the other. They live together, so they have the same germs. They came in because they were in daycare. You know, some families, they have no other way out. They have to work. They have to put their kids in daycare. So they put those girls in daycare. And think about it, daycare is like a germ like pre-COVID, it was a germ infested place to be. So hence they both got sick, and they get sick quick. Like they catch everything that's around them. So you really have to practice, they have to practice good hand hygiene, and their parents have to really be conscious on where they take them. But again, sometimes in that case, like they had no choice. So that's pretty much cystic fibrosis in a nutshell. But I'm saying like their secretions look like rocks. Like when they cough up, I know it sounds gross, but when they cough up their secretions, it looks like balls of rocks. That's how thick they are. And how is it diagnosed?
Through your sweat.
Sweat test. That's right. They can detect it through the sweat test. And now I think they do, like in the newborn screen, I think that's part of the newborn screen. So they can detect it earlier and sooner than later.
I think it is because my old neighbor had a baby over the summer and she was diagnosed with cystic fibrosis.
Oh, that's terrible.
I don't know how old she was when she was diagnosed, but I mean, she's only 9 months now, so they diagnosed it fairly.
How's she doing?
I don't know.
Yeah.
My parents still live there, so my mom was the one that told me about it, but I don't have any updates.
Yeah. So it depends on how like prevalent, like, and how strong their gene is. Depends on how well they do too. So, and as they get older, I feel like they run into more obstacles. Like they get sicker, obviously, but it does, A, it's how well they take care of themselves, and B, it's how strong the gene that they have is for it. It depends on how sick they get. So Any questions on cystic fibrosis? No. Okay. Pyloric stenosis. Now, what is pyloric stenosis?
That's where that muscle above the stomach is like pinched.
Yeah. So when the part of the stomach enters the small intestines, the pylorus, right? Pylorus, I think. Pyloric sphincter is spasmed or tightened and narrowed, okay? That when the formula, it's usually diagnosed very young. When the formula goes down the stomach and entering into the small intestines, the sphincter starts spasming, and it spasms and it pushes the formula straight out of the stomach, out of the mouth. So they'll get projectile vomiting, like projectile across the room. Like no reflux vomiting. Reflux vomiting is just a little bit, like this is like projectile. And that's because the sphincter is closing and it's actually forcing the formula, pushing it up through the mouth and out. So if you think about it like that, you'll never get it. You'll never get any questions wrong. But anyway, so this scenario is a 2-month-old little boy. Matthew is a 2-month-old boy. He's brought to the ED by his parents. When questioned, the mother states that her son breastfed well for the first several weeks, but recently he throws up very forcefully after feedings. He looks so skinny and sick, and he cries and is fussy all the time. Matthew is awake and crying intermittently. His color is pink and respirations are unlabeled. The emergency physician orders lab work and x-rays. Matthew is diagnosed with hypertrophic pyloric stenosis. He's admitted to the peds unit, scheduled for surgery. Because what they do, they like almost balloon it out and they open it up. Matthew's parents are worried because they don't want anything bad to happen to their baby. The father also states that he just lost his job and the family now has no health insurance. Matthew is prepped for the OR and a pyloromyotomy is performed later that day. He returns to the peds unit from the PACU with an IV of D5W, half normal saline, is infusing into his left hand. Matthew's vital signs are stable, and he is sleeping at present time. Both parents are in his room. Okay, so in this case, what are your priorities? What are your priority assessments and interventions for Matthew upon arrival? Priorities.
Isn't the
Say
priority?
airway.
Yeah, the
Airway, yes. Airway, he's got a secure airway. Breathing, he's breathing beautifully. Circulation, what about circulation?
Usually
He's
they're hydrated, right?
Yes, he's dehydrated, right? So the less hydrated we are, the less volume we'll have in our circulatory system, right? So he's dehydrated. Perfect. So that's your priority assessment and interventions. And you get that information when the mother states he looks so skinny and sick and he cries and is fussy all the time. Okay? What are the rationales for the priorities you identified? The rationale is basically, I just told you what the rationale is. Circulation, right? If you don't feed the body cells, the body doesn't do well. And eventually will decompensate. What are the key aspects of the history in this case that concern you? So now history is everything with the parents. So for example, today I had a baby. He came in, he had a TNA, and he came up to the unit post-op and he was like, he had obstructive sleep apnea, hence why he had a TNA. So he had tonsillectomy and adenoidectomy. and he was trisomy 21. Trisomy 21 usually have bigger necks than we do, right? And protruding tongue, all that stuff. So he had a surgery, then he recovered in the PACU, and they were like, you know what, he's not doing well. He's breathing really bad, so we have to push him up to the ICU. So they pushed him up to the ICU. When he came to the ICU, he was desatting like in the 85. His airway was so swollen, and he sounded like a croupy, snorting, like pig. I hate to say it, but pretty much like that. And we actually gave him racemic epinephrine because it helped open up his airway, which it did work. He received steroids in the OR, right? Steroids is to decrease the inflammation in the throat. And, you know, he just had a tonsillectomy and adenoidectomy. So, of course, he's going to be swollen. There's nothing you can do about it. You just got to support his airway. So we gave him a little oxygen, and he came right back up. But the mother was only Arabic speaking. So I had to get the translator phone and talk with her, try to get as much information of the background that I can to formulate this whole story, right? And she didn't really know anything. And I believe she didn't really know. And so if she doesn't know anything, we always say, mother is not a reliable historian. Okay, that's how we word it. She wasn't because I think that she's Arabic speaking and there's a huge language barrier, and B, nobody takes the time out to get the translator phone to talk to her, you know? So there could be a lot of factors into that whole situation, but history is so important. That's my point. So in this history, what are the key aspects that concern you?
Are we going with the scenario or the one you were talking about?
The scenario. So he throws up very forcefully after feeding. Bingo. Right there, you say, this might be a pyloric stenosis case. Okay. Then number 4, what additional information will you obtain from the parents? So what additional information would you obtain about hydration, right? Because that's our focus with him.
Mm-hmm.
Many diapers?
How many diapers a day, right? How much is he eating? Approximately how much is he throwing up? Is he throwing up the whole feed? What else? There was one type of formula he eats. When did this all start, right? What did you do about it? Did you give him any medications? Is he on any reflux medications? So that's additional information that you would obtain from the parents. So what lab work or other diagnostic tests would you anticipate being ordered? If he's vomiting and not getting enough hydration, what lab tests would you watch?
Like any of his electrolytes.
Electrolytes, right? That's huge. Electrolytes and BUN and creatinine. Okay, that's all kidney related stuff. What medication or treatment orders do you expect to be ordered pre-operatively? So meds, so a PPI, right? Maybe Protonix, Pepsid, pain medication, some Zofran.
Sedation meds, obviously.
Sedation meds, yep. But that you wouldn't give until the actual procedure of him going into the OR, right?
Oh, this is pre-op, sorry.
Yeah. Because you don't want to give sedation prior to the so close to prior to the OR because they could lose their airway and they can get too sedated. So, and have respiratory depression. What would you explain to the parent about Matthew's condition? You would just explain what it is, right? So you would say pyloric stenosis is what? A narrowing of the sphincter that from the stomach that enters the small intestines. Always use layman's terms because parents seem to understand that best. And especially if they're in a crisis situation, you start talking medical terms, sometimes they get so frustrated and they're like, what? What would you explain to the parent about Matthew's condition? Well, we just went over that. What assessments and interventions would be done post-operatively?
Uh,
Post-op.
probably see if he starts having wet diapers and stuff like that again.
Hydration. He probably will because he probably got a lot of fluid in the OR. But before that, what are you going to look at?
Incision.
The incision site, make sure it's clean, dry, and intact. What else?
Respiratory assessment.
Respiratory assessment. They just got out of the OR. They could be slightly sedated. Yep. And you have to bump up. You got to give them a little oxygen just to get them where you want to be. What about the GI system?
You start feeding them right away.
What?
See like if they can tolerate it.
So basically what you would do is you would listen for bowel sounds, right? Because you can't feed a stomach that has no bowel sounds. So bowel sounds are super important. So make sure he has bowel sounds, okay? If his stomach is distended and soft, that's typical. If it's distended and rigid or firm, that's not okay. Okay. Naturally, they are going to have some distension because they are going to be swollen. Because anything you touch inside the body, I don't care what you say, does have a result of some form of inflammation. I'll never forget, we were doing abdominal growths on a child that had stomach surgery. I forget for what for. And the surgeon who did the surgery came over and he was like, why are you guys doing abdominal growths? And we're like, oh, we just got to, watch out for neck and whatever. He goes, his stomach, I just manipulated his stomach so much. He said his stomach is going to be inflamed anyway. It's going to be slightly distended. He's like, so please stop. And we were like, okay, makes sense. So what actions would you include to provide a traumatic and family-centered care? So family-centered care with this family.
You're going to let them know it's not anything that they did wrong. It's just something that happens.
Reassure them, keep them in the loop, update them. That's all family-centered care, right? What are the implications of the family's lack of insurance? No surgery. Those are the implications. But coming through the ER, we have to treat everybody. Sometimes they treat it like a pediatrician's office because they don't have insurance. But we ethically we treat everybody. So there really isn't. I mean, excuse me.
They probably don't go to the doctor regularly because they don't have insurance.
Right, but implications of the so implications would be no follow-up care, no home care. That's big, right? Some parents that their babies get surgery, especially if they're first-time parents, are petrified to take this child home. So usually we set them up with home care to make them feel more comfortable for like the first 2 weeks. But in this case, he wouldn't get any home care because they don't have insurance. So, any questions on that scenario? Okay, meningitis. So what is meningitis?
It's an infection, right, of the meninges.
Yes, infection, inflammation, all of the meninges of the brain, which can cause seizures, total like a alteration in the balance of your cerebral spinal fluid, right? A decreased consciousness. Some of them get like really wild. They don't know where they are. And the parents swear to you that they're normal. That's how bad that they get. And you're like, really? This kid is normal? But they get like sometimes combative. Like that's how bad they get. So in this case, the setting is the PEDS ED at the medical center at Cohen's, and it's 4 p.m. So Jason, a 12-year-old boy, is brought to the ED by his mother on the advice of the pediatrician. The mother reports that the child has had a fever, vomiting, and that started abruptly yesterday. Jason has also been complaining that his head and neck hurt. That's a key finding, that his head and neck hurt. And this afternoon, the mother noted a rash on his legs. Rash indicates like virus, right? His temperature was 103.5. When she took it again about an hour and a half ago, the mother gave Jason Tylenol, but he vomited it almost immediately after he took it. On the way to the ED, the mother noted that Jason had become increasingly drowsy and lethargic. There goes his Glasgow coma scale, right? He has no allergies, and he received all the immunizations required to attend school. The mother opted not to give Jason the meningitis vaccine before Jason attended sleepaway camp, as the pediatrician had suggested. She was afraid to since Jason told her that he felt funny after he received the flu vaccine last fall. He returned home from camp 4 days ago. Jason's two younger siblings are with a neighbor. His father is away on business. The child has been placed in a bed in the isolation room in the pediatric area of the ED, and his mother is present. His mother's there. After introduction, the nurse begins to assess the patient. Okay, so the nurse walks in, she introduces herself to the mother. I'll be taking care of your son today. Following the lumbar puncture, Jason seems to be more, so basically with meningitis, or suspected meningitis, they come in and they get a rule out sepsis workup. So they'll get a blood culture, urine culture. If they have a trach culture, sputum culture, RVP panel, which the RVP panel tests for COVID-19, and all different like flu viruses, adenoviruses, the other coronaviruses. So these are tests that we have to do. Plus, we have to do a spinal tap, which is the lumbar puncture, because we got to test the cerebral spinal fluid that's in the back of the spine. We have to test it to see if there's any white blood cells. If there's white blood cells, then that indicates infection. Okay? So, following the lumbar puncture, Jason seems to be more somnolent and his responses are inappropriate. His apical and respiratory rate remain elevated and the systolic blood pressure is now 94 millimeters of mercury. There is no reading on the pulse ox, and capillary refill is noted to be more than 5 seconds long. So here, what are your priority assessments and interventions for Jason? Priority assessments. Airway, right, because they can get so confused that they lose their airway. And I've seen that happen. And that's like an emergency situation that everybody wants to avoid. Okay? So be prepared at all times that if these kids come in, they could potentially lose their airway because they can just pass out pretty much. So the priority assessments and interventions for him is airway. What is the rationale for the priorities you identified? So what is the rationale for an airway?
Needs to breathe.
Yeah, airway's always first. He's got to breathe, right? What is key vital sign changes or assessment findings that concern you? So um, within the scenario, he's got a temp that's 103.5. That's concerning, right? The higher their temp goes, the more disoriented they could be. That's just generally, that just happens. What else? His blood pressure, hold on. His blood pressure is 94 millimeters of mercury. That's pretty low for him. Okay, he's 12, that's low. So that's concerning as well. And what else?
The pulse ox and capillary refill.
Yep. There is no reading on the pulse ox, and his capillary refill is more than 5 seconds. Okay.
No reading, might be a stupid question, but no reading on a pulse ox, does that mean he has no oxygen circulating?
No, not necessarily. That just means that it may be too low to read.
What is the cutoff of a pulse?
So it depends on if you're normal and you have a normal heart, then your cutoff should be 92 or greater.
No, I mean what the machine will read.
That I'm not sure. But also too, if the pulse ox, if it's on their finger and they're like wailing around, it's not going to pick up. So the way to notice if your pulse ox is a true reading is if you look at the waveform, and if the waveform is very perfect and symmetrical and not all over the place, that means it's accurate. So for example, today with the TNA kid that I had, he came up to the unit and all of a sudden he's ringing, and I go over to him, I'm like, why is he ringing? And he's desatting in the mid 80s. So right away I say to myself, where's his pulse ox? It's on his finger. Then I look up at the monitor and I'm like, is that a true waveform? It was a perfectly sloped waveform. So I said, okay, that is accurate, right? Then I look at how the heart rate on the pulse ox, because those monitors detect your heart rate from the pulse ox. I don't know if you guys know that or remember that, but the heart rate is detected by pulse ox as well. So I look at that heart rate, and then I look at the EKG heart rate, and if they are within the same parameters, like if one is 151 and one is 155, then that means that my pulse ox is accurate. Do you guys understand that?
Mm-hmm.
It's kind of hard to follow, unless it would be easier if I could show you on a real monitor, obviously. So we spoke about the key vital signs. What lab work or other diagnostic tests may be helpful in determining the type of meningitis and the severity of this patient's illness?
So you're gonna look at the cultures.
Cultures, yeah, of course, right? We got to wait for our cultures to come back to see what it is. Our white blood cell count, is it high? What else? Our CRP. CRP detects any inflammation going on in the body. Okay. What else for concern of the head would you want to do lab-wise or radiology-wise?
CT.
CT or MRI, right? Neurosurge may request a CT or an MRI. I always like MRIs better because I feel like they're more detailed, but MRIs are more expensive. And they are just difficult to get, but they are very, I feel like they're very detailed. Whereas a CAT scan, they just throw them into the CAT scan and they're like, okay, we scanned them. And then they're like, okay, maybe we should get an MRI too. And I'm like, what's the point of that? Just you should have just done the MRI to begin with. Okay, so MRIs. What medication and treatment orders should the nurse expect to be ordered?
Antibiotics if it was a bacterial.
Yes. We actually would put this type of kid on prophylactic antibiotics until all the cultures came back anyway. So our drug of choice is usually ceftriaxone, always, because it covers everything. And then we also use, in this case, we use ceftriaxone and acyclovir. Acyclovir is an antiviral. So until the cultures come back, they will remain on acyclovir and ceftriaxone, okay, as a prophylactic treatment so that they don't get further ill. Acyclovir, you have to watch out and encourage PO fluid intake because it can put strain on the kidneys. So the goal is to drink a lot of water to flush those kidneys out. That's with acyclovir. Okay. What assessment changes would suggest treatment is effective?
If like his vital
Go
signs,
ahead, Kayla. What'd you say?
if like his vital signs went back to like normal range and his like
Yeah, of course. If he lost his airway, right? Hold on.
Improvement in his mental status too, probably.
Yes, his mental status, which is huge. Huge. So his mental status, his white count, his bloods, right? All those markers, the CRP, markers for infection would improve. What would you explain to the parents about Jason's condition?
It's kind of what it is. It's an infection on the brain. Yeah. You should get
Yeah.
back.
So this kid is, hold on, this kid is, he's 12. But any kid that is, and you might have learned this in OB, any kid that is less than 8 weeks old, okay, was just born less than 8 weeks old, and if they develop a fever, it's an automatic rule out sepsis admission to the emergency room. So let's say I just had a baby. He's literally probably 6 weeks or so. And I say to my pediatrician, he's 6 weeks now and he has a fever. She has to tell me to come bring the baby to the hospital, and the baby needs a rule out sepsis workup. So what do they do in a rule out sepsis workup? Sorry. They do CBC, blood cultures, RVP, spinal taps, okay? And then they start them on prophylactic antibiotics until the cultures come back. Most of the time, they're always like, you have to ask them, were there any sick contacts at home? Anybody sick at home? And they're like, no. Any visitors come to see you? Oh, my aunt came to see me. What, did she have a cold? I don't really know. And then boom, the baby has a fever, and then boom, has to come in for a rule out sepsis. So another thing that you guys may have learned in OB is group beta strep. Did you learn that yet?
Mm-mm.
No. Okay, so women have a normal flora, some activated, some non-activated, of group beta strep in their vagina. Okay, so when they have a baby at 36 weeks pregnant, they have, and you're gonna learn this in OB. At 36 weeks pregnant, they get swabbed. Okay. If the swab comes back positive, then during delivery, the mother must get IV antibiotics. Okay, because what do you worry about? You worry about when the baby comes through the birth canal. Okay, that bacteria can hurt the baby, which hence can cause meningitis. Okay, can get into their eyes, travel to the head. You never know. If the mother is negative, then she doesn't need any antibiotics. Me, I didn't care what I was. I always got antibiotics because I was like, I'm not taking a chance. I had a patient once that lovely family. The mother had a false negative group beta strep, which means when they swabbed her at 36 weeks, it showed up negative, but she was really positive. So she goes and delivers the baby, okay, with no antibiotics. Then the baby's born, and like 6 to 8 weeks later, the baby comes in with high fevers, and now he's seizing.
Yes.
He's got meningitis, which I'm telling you, neurologically devastated him. And that's all from a false negative group beta strep test. So these are why, and even too, like STDs, you have to worry about STDs within, if it's a more vaginal delivery or C-section, really. If they, if the baby develops a fever 8 weeks of life or less, you have to think about all these diseases that they could have gotten through delivery, right? You never know people's stories. Maybe the husband's having an affair, maybe the wife is having an affair, but they could really neurologically devastate the child. So but this kid is 12 years old, so he doesn't need, he's just here for rule out sepsis due to his meningitis. So hold on, the medication and treatment we went over, right? What assessment changes? We went over that. The assessment changes that would suggest that your treatment is effective was his neurological status would probably start coming back and his fevers would decrease. How might this child been infected, and explain the infectious disease considerations that may impact family, friends, and acquaintances? So, how might this 12-year-old have been affected?
He went to camp.
He went to camp. He didn't get the vaccine. There you go. Okay. What actions would you include to provide atraumatic and family-centered care with this family?
And not shaming them for not getting the vaccine.
Right. Empathy, right? Empathy is huge. Also too, for his blood pressure, what are you going to do?
What?
Say that again.
Fluids?
Yeah, fluids, normal saline bolus, right? Once you have the circulation there, your pulse ox should start picking up, because pulse ox is on the finger, right? If you have no circulation, where's your circulation shunting to? Your vital organs, fight or flight response, right? So you lose it in the fingertips, which always happens. And actually, some of these kids, they lose their limbs because they actually can get septic and lose their limbs. I've seen that happen too. So Jason becomes more responsive following the saline bolus. The pulse ox consistently reads 97 to 99%. The chest x-ray is done. What is the nurse's next priority?
I guess figured out it's bacterial, viral, and administering those medications.
Yeah, just follow up with the cultures, right? Update the family. Keep an eye on them. Make sure that the organisms come back so that you can see what the what the organism is sensitive to and start that specific antibiotic, right? But usually ceftriaxone is such a broad spectrum antibiotic that it covers everything and anything. Okay. Why do they want to do a chest x-ray?
Make sure he doesn't have any other infection or it's spread anywhere else.
Right. And he had like no pulse ox, right? So you want to make sure he doesn't have anything else underlying, like a pneumonia and whatnot. Okay. And that's it on that. Any questions on meningitis? Anything on pyloric stenosis or cystic fibrosis? No? You guys excited that it's almost over? When is your final?
I think like in May. Beginning. Like May.
So now you're gonna have a whole bunch of classes with no clinical, which is actually kind of nice because maybe you could focus more on that, right?
I think a little bit, but I don't know if it's that much.
I'm distracted at home anyway, so.
I know that's hard. So am I.
We'd have to do less schoolwork, I think.
Yeah.
I can say yes, but it's a big lie.
Anyway, all right, guys. That's pretty much it for tonight. If you guys do you guys want to go over anything else now that you have me here?
We have a test next week, but I don't know what's going on. So.
Oh, with Anne-Marie?
So much information.
Okay, well, you don't have a test on Monday though, right?
Next Tuesday.
The 23rd, right?
Yes.
22nd is us, and then 23rd is Tuesday.
Mm-hmm.
So maybe we'll use next week to go over those topics a little bit in detail if you need help with them.
Okay.
I don't mind that.
Yeah.
Since we reviewed everything, I'll go over everybody's last and final questions, and then we could review for the test.
That would help.
Do you guys have a study guide that she gave you?
She doesn't. That's the issue.
Yeah.
Just
Yeah,
the
she
notes.
doesn't give us any like focus areas. Just
Like 15 PowerPoints.
What is it on?
There's
If I have the PowerPoint.
a bunch.
It is on the premature infant and issues with fever, infection, inflammatory, renal disorders, communicable disorders, blood.
Hematology.
Yeah.
What is it under? Do you know? In Canvas. Modules?
She just breaks it down into modules. So, hold on.
It's like week 6 through wherever we're at now, I think.
9. Yeah, or something like that.
Yeah, I don't think I have that. I don't have that
Just
one.
has like each week has like 2 different topics. Like for tomorrow's lecture, the Panopto is an hour and a half long.
Oh. And it's
Yeah.
like her just talking?
It's just her talking.
The whole time.
The entire
And it's a recording, right?
On speed like 1.5, 1.75. So it's like 45 minutes instead of an hour and 15. Because she talks so slow that like it basically sounds normal when it's sped up.
Okay, so what did you say it was on? Because I'm on the syllabus now.
Pre-term, would be, you're looking at her like course schedule.
The syllabus.
There's like a course schedule on there that like breaks it out per week.
Yeah, if you scroll down in her syllabus, you'll see the course schedule, and then it's weeks 5 through 9 on that.
Okay, so we are on week 9? No.
Yeah,
Yeah.
But what is the test on?
everything from week 9, week 8, week 7, week 6, and week 5.
That's a lot of information.
Mm-hmm.
It's a lot.
Yeah, just posted in the chat, like the actual topics.
Oh yeah, that's like copied. Yeah, she just doesn't give like an outline, so it's just a shot in the dark while we're studying.
A lot
Probably
of,
like 6 hours worth of Panoptos, if not more.
Oh gosh. Does
Oh,
she do a
Lord.
review Panopto?
what's that?
Does she do a review Panopto?
No.
No. All right. We'll do this next week. We'll go over all this.
And she gives us like 4 math, but then it's like 36 questions out of all those topics, so you really don't know what she's gonna pull from.
Of the math questions?
No, the math is fine, but there's only 40 questions. I guess they changed it in the nursing department.
Mm-hmm. And she
What-
doesn't she do like ABC, no D?
Or she does all 4.
Does
She
do all-
does. See, she used to not. I wonder why she doesn't do it anymore. Okay, so go ahead.
Yeah, like she just doesn't, there's only 36 questions because 4 of them are math. It just doesn't allow much wiggle room. Like if you get 2 wrong, it's a 95.
Well, you know her maths are going to be calculations, right?
Yeah, those ones are easy.
So those, I mean, that you could figure out by just practice.
Mm.
It's the topics that are probably challenging, right? Do you guys have review NCLEX books?
Not yet, no.
Just for ATI.
I would highly recommend. Well, the ATI book, doesn't the ATI have like the like NCLEX questions?
I think there's like 5 at the end of each topic.
Oh, that's it?
It's not a lot.
Oh God. In nursing school, I had a review book. It was like an NCLEX book that I would take the topic of discussion and I would go into the book and find like the few questions that were on that topic and do them. Because this is where they're getting all this information from. So, because the goal is to prepare you for the NCLEX. So, anyway. All right, so we'll go over this next week. All right.
Good.
Sounds good.
Sounds good?
Mhm.
All right, I'm just going to stop recording.